So we have a quiz, and remember there are 10 GIEQs coins for the first correct response, but you have to put your email address in. What was the pooled sensitivity of unsedated transnasal endoscopy for detecting intestinal metaplasia in biopsies according to the meta-analysis by Hubetzer? I'm not sure how to pronounce that. Was it 78, 85, 89, 93, or 95%?
So capsule sponge test concept is extremely simple. So this is a nurse-administered cell collection device coupled with laboratory in situ assays. So it's a capsule tethered to a thread. The capsule contains a compressed sponge. The patient swallows the capsule, which dissolves in the stomach over 5 to 7 minutes. And then the expanded sponge is retrieved simply by pulling on the thread by the nurse, and it collects a pan-esophageal sample. So that will be gastric cardia cells, Barrett cells if they're present, and squamous cells. And these are then put in a standard preservative pot and sent to the laboratory for analysis. So we heard earlier today about how, unfortunately, we don't often do a very good job with esophageal cancer, and there are too many missed post-endoscopy upper GI cancers. And Nigel Trubgill has really drilled down on the potential reasons for this and concluded that really many of these are potentially avoidable. And so what can we do to do better? I think in expert hands, fantastic, but unfortunately there is variation in quality in endoscopy across and between our centres. So I think what we really need to do is to raise and unify the standards for detecting Barrett's and surveying it. So we're currently in the setup phase for a very large screening trial in the UK called BEST4, which will randomise 120,000 patients. 40,000 will be allocated to the sponge arm. The age reflects the risk of the condition. So females are older age than males. They all have to be on medication for reflux, which can be over the counter or prescribed. And this will follow out patients out to 10 to 12 years with a combined endpoint of morbidity and mortality.
If your endoscopist doesn't know what they're looking at, you're not going to make real impact in terms of patient care. So we recognised the problem and performed an intervention, as Roland likes to call it. So we bravely invited Roland and John and Nigel to Scotland, and we put 15 of our senior consultants performing upper endoscopy, but all performing Barrett's, into a room and locked the door and had them thrash out what was upper GI best practice. And then we invited Nigel and Matt and Rehan back to promote the information that was given at the first event on early lesion recognition, but in a lot more detail. And if anyone wants access to either that online webinar or the consensus statement that came out of our best practice, they're available online, and we'd be happy to share them with anybody.